Eunice. Excellent. So my name is Hannah. I am a patient access coordinator here with Northwest Medical Specialties, and I am also a member of the cancer support community. I wanted to introduce cancer support community and who we are. The cancer support community is the largest professionally led nonprofit network in the world, providing free cancer support to everyone in the community who has been touched by cancer. Through our partnership at Northwest Medical Specialties, we can bring free programming like these educational workshops, healthy lifestyle classes, social activities, support groups, and other resources and support. We do this so that no one has to face cancer alone. I just want to go over a few housekeeping rules tonight. You have noticed upon entry that you are muted. We do ask that you remain muted for the entirety of the presentation. This way everyone can get the most out of tonight's presentation. Well, also, we would like to ensure that everybody's name is reflecting correctly on Zoom. So to correct your name, if needed, just right click on your name. Your name can be found in the left-hand corner of your screen. Please right click and select rename. This prompts you to enter a new screen name. Please put in your first name with last initial. And also, if you have a guest present, please add their name as well. This will help ensure that everybody gets entered into the raffle drawing after the question and answer section tonight. So please do not go anywhere after the presentation is over. You must be present to win. If you have any questions at any time throughout the presentation, there is a feature called chat. Feel free to write your questions anytime and we will ensure to address them. And then another handy tip is in the upper right-hand corner, there is a view button. If you click that and then select the speaker view, this will give you the best viewing option for tonight's showing. So again, tonight is a workshop on metastatic breast cancer with Dr. Frank Senecal. Dr. Senecal is a hematologist and oncologist with a clinical focus in breast cancer and general oncology. He is currently the Director of Oncology for the Franciscan Healthcare System. He is formerly the Chief of Staff at St. Joseph's and St. Francis Hospital. He was also the Medical Director of Hospice of Tacoma and Chairman of the Department of Medicine at St. Francis Hospital. He is the founder of the South Sound Cancer Foundation, a foundation that strives to bring groundbreaking clinical trials and cancer research to the South Sound region and to provide residents with cancer treatment options that are unavailable. Dr. Senecal enjoys being with his family and 6 grandchildren. He enjoys hiking, fishing, and climbing the great outdoors. Dr. Senecal became a provider in hematology and oncology so that he might be able to use the best science with compassionate care for those who need him. Without further ado, may I present Dr. Senecal.
Hi, thanks for tuning in. Thanks an awful lot for such a nice introduction. We made up most of that about me. Just kidding, but thank you, Hannah. So we're going to talk about metastatic breast cancer, and we have a series of slides to look at that I think will be helpful in kind of framing the discussion. These were developed by a medical oncologist in 2020. They are a little bit dated. It's just that this whole area in oncology changes so fast that I'll try to identify the areas where they're a little dated. Okay. It was developed by Cancer Support Community. The program was, as you've already heard, we have sponsorship by Lilly Oncology and Novartis. I don't have any affiliation with any of the pharmaceutical companies. And we'll start off with kind of a definition of what metastatic breast cancer is, the importance of partnering with a healthcare team, various treatments that are used in metastatic breast cancer, some of the side effects that folks are faced with, and then that important psychological and spiritual issue of living with metastatic breast cancer. So a couple of important points to start with, that the more you know about the disease, the more you understand about it, better you educate yourself about it, the better questions you'll ask, and the better advocate you'll be for yourself. It seems a little bit overwhelming initially, but you can learn about the disease and you can learn about the treatments, and be sure to ask a lot of questions, and use your physician and use your friends, use the support groups that are available, all to kind of learn about this disease. So get support, stay positive and stay optimistic. And I kind of always am. I'm always optimistic that things are going to get better, that we have good options for patients, that this is a disease that's really, we're in there for the long run, because it's a chronic disease really that we're faced with. So what do we mean by metastatic breast cancer? Well, the definition is really cancer that's spread outside of the ducts and the lobules of the breast to a different portion of the body, and beyond the axilla, for example. So to other lymph nodes in the chest area or anywhere else in the body, or to other organs, for example, to the bone, which is a very common site for metastasis. Those are areas that the cancer likes to go to. The liver is another area that it can spread to easily. The lungs, for example, pretty commonly. Not very commonly does it spread, for example, to the pancreas or to the kidneys. Now, even if it spreads to the lungs, we still refer to this as metastatic breast cancer. We don't refer to it as lung cancer. So your doctor will emphasize that, and in discussions with folks, it's important to understand that it's metastatic breast cancer that we're referring to, not lung cancer or not bone cancer. So this is a slide to remind us how important it is for you to collect that healthcare team that you can work with. You need one that you can trust, where there's expertise in the disease. They understand the disease. A lot of groups these days, medical oncology groups, for example, have a group of physicians who have certain interest or expertise in breast cancer. Breast cancer, as you know, is the number one most common cancer in women, or life-threatening cancer in women. So it's not surprising that there are quite a few experts in the Northwest in regard to breast cancer. And so you want to try to hook up to one of those physicians if you can. So you need somebody that you can talk to and that you can trust, and it's somebody who is, I think, also a team player, that has others that work with them. For example, has good access to research, such as clinical trials, that has perhaps a social worker involved, that has radiation oncology involved, that has a good relationship with the surgeon. That, in other words, that you build this team so that they can work together in order to give you the best outcome, best treatments. Physical therapist, occupational therapist, dietitian, maybe naturopath. All of those folks are important in building that team. Now, when you go in and communicate with your oncologist or any of your providers, be prepared. I mean, write down your questions. There's just a way, we all know, of going into the doctor's office and our minds kind of go blank as to what to discuss. Important to just write those things down ahead of time, maybe with your partner, your spouse. What are the questions that you want to get answered? What do you want to understand a little bit better? So that you can communicate those to your doc or to your provider. Let me also say that part of the provider environment these days is our nurse practitioners and our physician's assistants. And I have both a nurse practitioner and a physician assistant, both of which have expertise in breast cancer and are pretty capable of answering most questions. And if they don't know the answer, then they'll come grab me. And if I don't know the answer, then we'll go outside and get the answer for you. So you'll not uncommonly have appointments with a mid-level provider like a physician's assistant or a nurse practitioner. So don't be afraid to ask questions. Don't be afraid to get a second opinion. You've got to be able to communicate well with that physician. I would hope that a doctor would not like talk you out of a second opinion or talk you out of a particular approach that you wanted to take. That's not our role. Our role is to really kind of educate and facilitate. So I think you'll find that that's true with most physicians in this day and age, that our focus is on really communicating and hopefully listening to you, so that your needs can be met. When I'm at my best, that's what certainly I try to do. So keep a list of questions. Can talk to your healthcare provider about how do we like to communicate. Taking notes is important. All these things are really worthwhile in order to understand the disease well and make sure that you're keeping up on it and have a good understanding of what your condition is. This is an important one. You know, a lot of us take over-the-counter medications or supplements or herbs and that sort of thing. Sometimes that's fine. Sometimes they can result in drug interactions because, you know, the drugs that we use are kind of can be pretty complicated and can affect certain enzyme systems in the liver, so that if you add in additional chemicals to your system in the form of herbs or supplements, there can be drug interactions. So it's really important for us to know if you are taking any herbs or supplements. Lots of times, if I don't know if it's safe or not, I'll ask you to contact a naturopath or see a naturopath so that they can go over those supplements and make sure that they're in your best interest. Important to know that those herbs and supplements are medications as well. Just because they come out of the ground and they're grown organically doesn't mean that they can't have serious consequences. They also may have good consequences. But I want to make sure that you have an expert helping you with that, so that if the oncologist doesn't know, then I think it's important to speak to a naturopath who does. And there are some naturopaths in the Northwest that have a particular interest in oncology. So drug interactions these days are huge because of the number of medications that are out there and the potential for interactions. But there are good systems for assessing for those interactions. I use a system that allows me to look at the other medications that a patient's on and make sure that they're not interacting with the ones that I'm prescribing. So all that's pretty important. So how is the treatment of metastatic breast cancer different from early stage breast cancer? Well, like in most things, this is on this slide deck, it's pretty close to being accurate, but not 100%. So one thing is that we want to minimize symptoms. In other words, the idea of treatment of metastatic cancer is, first of all, to reduce pain and discomfort, to reduce shortness of breath if that's an issue, to try to make sure that the patient is more comfortable with our treatment. We want the patient to be functional, to be able to go shopping, to be able to get out with the grandkids, to be able to um, do the things that they like, to attend a card party, uh, to knit, to sew, to go to their child's play, to attend sporting events. So being functional, that's the whole idea. Now, that all means optimizing quality of life and, of course, extending life. Usually, if we can optimize quality of life, then we extend life. Um, we want to stop the cancer from progressing. And there are many treatments that are available in metastatic breast cancer that we'll talk about, and some can be very effective. Sometimes these drugs can cause significant side effects that we have to be careful of, but really in all situations, the goal is minimize any symptoms that the cancer is causing, maintain function, optimize quality of life, and extend life, um, trying to minimize the activity of the cancer. Now, I'd have to say that, the old adage of metastatic cancer, breast cancer is not curable is not completely true. And there are some reasons for that. That sometimes a patient will develop what we call metastatic cancer, and it is potentially curable, particularly if when the metastases start or the spread of the cancer starts and it's a very limited amount of spread, like just to the area under the arm, or just to one single spot on the skin, or maybe even one spot on the bone. So there can be treatments that can be given that can be very effective, and treat that single or those two metastatic sites, and the patient can live essentially a normal lifespan. Now, that's not common, but it can occur. Also, there are certain kinds of breast cancer, and I'm particularly thinking of HER2 positive breast cancer, where there are so many options for treatment these days that are effective, that some patients that have advanced metastatic disease, by that I mean many sites of disease, can enjoy a very long life and not have the cancer progress at all, because there are so many good options for treatment. Okay, so these are things that are probably a good idea for you to really understand pretty well if you have metastatic breast cancer. One is, what are the characteristics of the cancer? And these are kind of global subtypes, groups, how we group breast cancer. Is it estrogen and progesterone receptor positive? So the ER and the PR stands for estrogen and progesterone. Is it HER2 positive? HER2 is a particular protein that can be measured on the surface of the cancer cell. Really important to know if the cancer carries that protein, because we now have targeted therapy for it. Or is it triple negative, which means that it doesn't have the estrogen receptor, the progesterone receptor, or the HER2 protein? And so that's a unique situation, probably about 20% of our patients. And that's a kind of breast cancer that you definitely want to know about. And if you have that, then you definitely want an expert opinion. You want to know what treatment's been recommended to you and why. What's the rationale for it? How is the treatment going to work? In other words, what's its mechanism of action? Is it a chemotherapy medicine? Is it an anti-estrogen medicine? Is it targeting a particular target like the HER2 protein? And then really importantly, of course, what are the side effects? What can you look forward to? There are going to be probably short-term side effects that you occur during the treatment or the week or two after the treatment. But then also you want to know long-term side effects. Some of the drugs can, for example, injure the bone marrow and cause your bone marrow to not function as well. Some of the chemotherapy drugs that we have can actually hurt the heart. And some of the chemotherapy drugs that we have can cause neuropathy. That's numbness and tingling in the fingertips and the toes. And all of those issues are important to know about. Is that medication that you're getting going to cause those sort of problems? And if they do, how do we manage them? What support services are available for my family? And how do I get information about the cost of care and insurance coverage and all of that? Most offices these days will spend a considerable amount of time um, looking at your insurance, trying to determine coverage from the insurance company, and making sure that you're not left with a big bill. Um, Finally, an important part of this is clinical trials. What clinical trials might you be eligible for? And clinical trials are really important. It's how we advance the science of all of this and understand cancer better. But also, sometimes a clinical trial will bring a treatment to a patient. And in fact, we hope that this is true, bring a treatment to a patient that they otherwise wouldn't have access to, that they wouldn't be able to access or get normally. And that agent on the clinical trial may be very effective in treating their disease. So that's all pretty important. So trials, you want to make sure that there's some opportunity for participating in a clinical trial. Um, this is a list of treatment options. Um, and for metastatic breast cancer, usually the treatment is what we call systemic. In other words, it's something that you take either orally or intravenously or as a shot that gets to the body wherever the cancer might be hiding. Sometimes it's hormone therapy, sometimes it's chemotherapy, targeted therapy or immunotherapy. I think that was misspelled. So a variety of different options that might be available. And it's true that sometimes we use surgery or radiation therapy with metastatic breast cancer, and it can be a really important tool. For example, if a patient is is diagnosed with metastatic breast cancer, it's not uncommon for the presenting symptom to be pain, maybe pain in the back because of a spread of the cancer to a vertebra or to the pelvis. And radiation therapy to that site can be very, very important, can quickly bring that pain under control so that the patient's quality of life is improved. So sometimes there is a recurrence of the cancer on the skin or under the axilla or even in the breast. And then surgery might be an option for the patient to improve their quality of life and hopefully control the cancer. So sometimes we'll do surgery, even though there is metastatic disease. So I think that, this is where the art of medicine comes in. You hopefully have a physician who has quite a bit of experience, has access to clinical trials, will talk to you about um, how you're feeling, what your priorities are, um, discuss the severity of the symptoms, what they're worried about. Are they worried about involvement of the bone? Are they worried about involvement of the liver? Um, we have to take into consideration the patient's age as well as their health status. In other words, um, do they have other healthcare problems that are important to take under consideration? a geriatric patient that is 85 years old frequently cannot take the same kind of treatment that we might give her daughter who is 40 years old. So important for all those things to be assessed. And in fact, in my practice, I like to do a geriatric assessment for our older patients with breast cancer to determine really what their status is, how functional they are, what kind of support they are or they have, what their emotional condition is, all of those things which can be helpful in defining what might be a good treatment for that patient. And then there are certain tests that are important to do on the cancer that help direct us with what kind of treatment might be best. And again, that looks reminiscent of a prior slide, the estrogen receptor and the progesterone receptor and HER2. It's kind of a busy slide, but it gives you an idea of kind of options that the oncologists or things that they're going through in their mind when a patient is diagnosed with metastatic breast cancer. They want to be thinking about the kind of cancer that it is and the kind of simplistic evaluation of it is on the left-hand side where we look at these biomarkers again, the estrogen and progesterone receptor, HER2. It gets more complicated than that because in many cases we'll also do molecular testing, which allows us to kind of dive into the cancer and in a very in-depth fashion, analyze the molecular makeup of the cancer. Why is it growing? How is it growing? What other genetic mutations might be driving the growth of the cancer so that we might be able to inhibit it a little bit more effectively. So this slide, then, these check marks relate to these various forms of cancer and what options might be used. Just to kind of go over various hormonal therapies, one of the most important drugs that was really ever developed in oncology is a drug called tamoxifen. It's probably saved more lives than any other single drug for cancer care in the world ever. And that's because breast cancer is pretty common, and tamoxifen is used now around the world pretty frequently, and it's pretty effective, and it's cheap. Tamoxifen is a selective estrogen receptor blocker. So it blocks the effects of estrogen. Basically, what it does is that within the cancer cell, about 70% of the time or so, we have a protein in the nucleus of the cancer cell referred to as the estrogen receptor. And on that protein is a small cleft in the protein that binds estrogen. And estrogen, either in a premenopausal lady or a postmenopausal lady, is floating around and is in the environment, is in the serum, is in the cells, and can penetrate through the nucleus and bind to that receptor. And then that sets off a whole cascade of events with the protein becoming activated and then stimulating the production of other activators or co-activators, we call them, that result in DNA activation. Certain genes get activated that promote the growth of the cancer. Well, tamoxifen blocks that cleft in the estrogen receptor. It does it beautifully. It just sits right in there and it doesn't let estrogen bind to it. It was developed as a birth control pill for rats, believe it or not, in England. And it worked pretty well as a birth control pill for rats, but they did find that the rats primarily didn't get cancer, and they just kind of fell into this identification. And so that set off a whole series of research that proved how tamoxifen worked in this estrogen receptor. We use tamoxifen very frequently in premenopausal women. So in women prior to menopause, because it's quite effective in that group of patients. Toremifene, I won't spend much time on, but is a similar drug to tamoxifen. The aromatase inhibitors are used predominantly, almost completely, for patients who are postmenopausal. And it's very effective, these three drugs. Arimidex, we studied Arimidex in the first large clinical trial here in Tacoma, probably about 18, 19 years ago, when we were part of the first international trial. I was asked to present some information in Geneva in regard to our experience with Arimidex way back then. What these medicines do, all three of them, basically reduce the production of estrogen in a postmenopausal lady. It turns out that even though you're postmenopausal and the ovaries are asleep, that estrogen is produced in the tissues. It's in the fatty tissues where it's produced, like the breast, the butt, the thighs, all those areas. And the more fatty tissue you have, the more estrogen is produced. These medicines do a great job of blocking the formation of that estrogen. They block an enzyme called aromatase, and they do it very effectively so that estrogen levels drop dramatically. This works very well in women with postmenopausal metastatic breast cancer, a very effective treatment. SERDs are down regulators of the estrogen receptor, and they're similar to tamoxifen in some ways, but instead of blocking the estrogen receptor, they not only block it, they actually destroy it. So the estrogen receptor is deactivated completely. Again, a very effective strategy. And fulvestrant or Faslodex is the agent that is most commonly used, that is in that category. That's given as a shot, an IM shot. It turns out that oral agents that have the same basic effect are being developed and tested right now. LHRH medications are medicines that put the ovaries to sleep. Now, in a postmenopausal woman, they're unnecessary because the ovaries are already asleep. But in a premenopausal woman, sometimes it's important to suppress ovarian function. And if the patient has metastatic disease and it's estrogen sensitive, it's a really good idea to suppress ovarian function. So these are two medicines, gaserelin and leuprolide, that achieve suppression of the ovarian function. They're given as a shot, usually given on a monthly basis or every 3-month basis, and work well to accomplish that job. So as you can tell from my comments, that menopausal status is really important as to what medicines we use. The hormone receptor status is really important. In other words, we've got to know if it's estrogen receptor sensitive or not. Knowing if the patient was treated recently with other hormonal agent is important. Of course, most of our patients would rather they not take estrogen, which would be counterproductive. And there can be side effects of these medicines. Usually none of them are dangerous side effects, but there are side effects that we need to work on in order to try to make it a bit more, the experience a bit better for the patient. This is chemotherapy, and chemotherapy is probably a pretty easy discussion. I don't really like chemotherapy. I never have liked it. Um, it's kind of our go-to approach. In some circumstances, we have to use it. There are different mechanisms by which chemotherapy works, but basically, these are medicines that are designed in a um, very carefully controlled way to poison the cancer cell. You notice I said very carefully controlled, so that if you give too much of some of these, it'll hurt the patient significantly. So the doses and the side effects have to be carefully monitored. Um, they work through different mechanisms. Sometimes they work by um, damaging the DNA of the cancer cell. For example, the drugs on the top there, the anthracyclines, work through that mechanism. The second group of drugs, the taxanes, work through a slightly different mechanism. They uh, affect cell division and block the ability of the cancer cell to divide effectively. And finally, the platinum-containing drugs are also inhibit appropriate function of the DNA. Other drugs may affect other components of cell metabolism, such as these antimetabolites. And the drugs here, the microtubule inhibitors, again, work through a mechanism by which cell division is impaired. All of these drugs have some side effects. I recently chose a drug for a patient called Xeloda, which is an oral chemotherapy agent. I tend to use it quite a bit if I need to use a chemotherapy drug, because it very frequently has side effects that are quite manageable. I gave it to this patient, and for the past 3 weeks, she has had diarrhea from it. It didn't cause diarrhea right away, but it did after about 3 weeks of treatment, and it's been terrible for her. And I chose it specifically because I was thinking that she would tolerate it very well. Just turns out that her body does not metabolize the Xeloda effectively. And she's one of the 2 to 3% of people that can get into trouble with the drug. So in spite of my choosing the drug because I thought that the side effects would be modest or minimal, I've caused all kinds of problems for the poor lady. So it just shows with the best intent, you can still get into trouble. So if chemotherapy is to be used, and let me just say that for most of us, chemotherapy is not the first option. That usually, if it's possible to use a more targeted therapy or a hormonal therapy, if the cancer is estrogen sensitive, that's the preferable option. In some circumstances, if that therapy is not effective or working, or the cancer is immune to those forms of treatment, then chemotherapy is what we need to use. Hold on just a second. My sweet wife is calling me. Yeah.
So dinner has arrived.
Okay, I gotta talk. Okay. So it requires really that the patient and the doctor have a good discussion about what chemotherapy options might be available, what would be a good option for the patient, what the side effects might be, how to control those side effects, etc. And then also, this is a time when talking about clinical trials is valuable. Are there other agents that are being tested that might have less side effects and be better tolerated? I'm going to talk just briefly about targeted therapy. And this involves a whole spectrum of medications that have been developed. When we say targeted therapy, what we're referring to is that either on the surface of the cancer cell or within the cancer cell, there is a target. It's usually a protein, oftentimes a protein that can be targeted with a specific medication, kind of a guided missile sort of thing. So Herceptin was one of the first targeted therapies developed in breast cancer and is directed against the HER2 protein, a protein that sits on the surface of the cancer cell and plays an important role in allowing the cancer cell to grow and behave in a malignant fashion. Herceptin attaches to that protein and blocks its function, but in addition, attracts other components of the immune system that facilitate the death of the cancer cell, killing the cancer cell. Very, very effective agent and revolutionized the treatment of this kind of breast cancer, HER2 positive breast cancer. Now, it doesn't do much for HER2 negative breast cancer. It's not very effective because you don't have the target. But in cancer's cases, and it's about 20-25% of breast cancers are going to be HER2 positive, it's dramatically effective, or it can be dramatically effective. The second, actually pertuzumab, which is the one that's listed first, subsequently came along about 8 years ago and is also an effective antibody directed against the HER2 protein. It attaches to a slightly different spot of the protein, but is also very, very effective. Sometimes we use the combination. This is a list of typically oral medicines. The prior to the Herceptin and Perjeta are given intravenously. These other medications, the tyrosine kinase inhibitors, are oral, and they also block the activity of the HER2 protein. So they keep the HER2 protein from carrying out its signaling process. It also can be very effective, even if the cancer is spread to the brain, particularly that medicine number 3 down there, tucatinib, is looks like a game changer in regard to cancer cells that are HER2 positive that have migrated to the brain. It penetrates into the brain well and can be effectively used. Other antibody drug conjugates or medications like Herceptin are medicines where Herceptin, which is that antibody that I mentioned that attacks the HER2 protein, it's possible to couple a chemotherapy molecule with that protein, with that antibody. In other words, take the Herceptin molecule and couple or link a molecule of chemotherapy to it. And those medicines that you see there, adotrastuzumab and famtrastuzumab deruxtecan, are 2 examples of how that's been achieved to result in very effective treatments for breast cancer. They carry the HER2 protein. The third one there, sacituzumab, is for triple negative breast cancer. So this is not against the HER2 protein, but many breast cancers will carry a protein called TROP2. And that's the target for this medicine. And it can be very effective for that kind of breast cancer. Finally, the mTOR inhibitors that I won't spend a lot of time talking about, but I often use in the clinic and are effective in blocking a certain growth pathway that the cancer cells can use. there's so much to discuss on this slide that that is important. So let me tell you a little bit about PARP inhibitors. You may be familiar with the fact that about 10% of breast cancers appear to be inherited or genetically related. In other words, passed on from generation to generation. About half of those are due to a BRCA1 or 2 gene that has been mutated. So these are genes that everybody has, and these genes are responsible for allowing healing of our DNA. They're like little carpenter genes that when they function correctly, they heal our DNA. Critical, really, for us to stay healthy. And it turns out that our DNA in our cells is frequently kind of nicked and cut, and there are little deletions and alterations in it that need to be fixed. And these BRCA genes are what God gave us to repair those genes, or so that there's not mutations that develop. Well, unfortunately, in some patients, the gene doesn't work. And if the gene doesn't work, then that means that those little nicks and cuts can accumulate and the DNA never gets repaired in our genes. And certain tissues like the breast and the ovary are particularly susceptible to becoming cancerous because of those mutations that occur. If the patient had a functional BRCA gene, cancer would never happen. But they don't. So the cancer does happen. Well, it turns out that we've known about this for about 25 years. And now we are pretty good at identifying patients that have this mutation and don't have a functional carpenter gene or BRCA gene. They can't fix their DNA. Well, it turns out that medicines have been developed to fight those particular cancers that occur in patients who have BRCA mutations, and they're called PARP inhibitors. And they take advantage of the cancerous cells that have that alteration in that BRCA gene and can be very effective, very useful. Now, the next group of medicines that are there, I don't want to bore you to death, but this is a pretty important group. This is particularly important for HER2 positive breast cancer, for hormone responsive breast cancer, estrogen receptor positive breast cancer. And there are 3 drugs in this category, and they're called Verzenio, Ibrance, and Kisqali. And they're what we call CD4/6 inhibitors. And it turns out that in hormone responsive breast cancer, that is, in other words, estrogen sensitive, that that there are alterations in the cell cycle, that are alterations in certain enzymes in the cell cycle that drive the growth of the cancer, that make the cancer grow in a more sustained fashion without any inhibition. And these medicines very effectively block that. They keep that from happening. They block that cell cycle process. And they can be very effective. In fact, for metastatic breast cancer that is HR positive or hormone receptor positive, they're the major component of our treatment. In addition, we often use those aromatase inhibitors or Faslodex, which I mentioned before. So we use a combination of things, but very often one of these medicines is used. Okay, so it can be very effective. It's not a cure, but for some of our patients, it means the disease can go into remission for a year or 2 years or 3 years. So that's that's taking a pill or two, or a pill and a shot once a month, not taking chemotherapy, and the disease is completely controlled. So pretty good therapy. Finally, the new guy on the block is this drug called Piqray, or alpelisib. And this is a medicine that blocks a certain pathway in cancer cells that it frequently is used to grow. I have a modest amount of experience with this. The drug is a tough one to tolerate for the patient. It tends to cause diarrhea that you have to carefully control. It tends to cause elevated blood sugars, in other words, diabetes. All because those, the diabetic pathway, for example, is a pathway that is activated because of this agent. So you need the right patient and the right situation in order to use these drugs, and a patient that's pretty motivated. So those are a list of drugs that are used typically to treat patients with metastatic breast cancer. As you can tell, it's important to know what kind you have. Is it estrogen receptor positive or not? Is it HER2 positive? Is it a combination? Is it triple negative? All of those things are important and allow the oncologist to select what might be the best treatment for the patient. Again, want to emphasize the importance of clinical trials. Immunotherapy, I'm going to comment on that just briefly, but we've all heard of immune therapy, and it clearly is one of the big breakthroughs in the past 5 or 6 years in oncology, and can be very, very effective for certain kinds of cancer, like lung cancer, for example. In breast cancer, it's been a harder nut to crack, to be very honest. Most breast cancers so far have not demonstrated sensitivity to the immune therapy medicines that we have. That's not 100% true. There are patients, particularly those with triple negative breast cancer, where immune therapy may be a good option for them, and it can be effective. This slide comments on a medicine called atezolizumab, or Tecentriq. I don't pay too much attention to that because that's actually a medicine that we're not using presently. But we do use a medicine called Keytruda in this situation, where a patient's cancer looks as if, by certain tests that we do, that it might be sensitive to immune therapy. And it can be very, when it does work, it can be really effective, very effective. So immune therapy, particularly for triple negative breast cancer, is an area that we're actively involved in researching and pursuing. Again, a slide about clinical trials. As you all know, the idea of clinical trials is to find better treatments for our patients. It's very important. Probably the best, no, maybe that the cancer support community's website is pretty good for clinical trials, but I can tell you that cancer.gov/clinical trials is a good way to access what clinical trials are available in the region. That's what I use. So pretty much everything that I've mentioned has side effects to it. So it's hard to do just 1 or 2 slides on side effects, but it really is important for the patient to be educated prior to the initiation of treatment, so that they have written material and as well as have listened to a nurse practitioner or to the doctor describe what side effects to look for and how to manage them. So very important. And then important for the patient to track those side effects and communicate them um, in a in a timely fashion so that the care team can take care of them. Many times we can kind of bring those things under control pretty quickly if we know about them. And and sometimes the side effects kind of sneak up on you. Um, you you don't initially have them and then you do get them. For example, my patient that had the diarrhea, nothing happened for the first 3 to 4 weeks. She did quite well, but then the diarrhea started and then it became much more of an issue. Here's a list of some of the side effects that can occur. I'll let you just kind of look through those. One real bothersome one is that third one from the bottom, neuropathy. That's pain and discomfort, tingling, and such in the hands and the feet. There are a lot of different reasons for developing that, but chemotherapy is certainly a big one. And there are several chemotherapy agents that are well known for doing that. The last point there, the cognitive and emotional changes, very common because we're giving you these medications for patients to notice that they think their focus is down a bit, that their short-term memory isn't quite as good as it used to be. They may feel emotionally labile, like short-tempered, for a variety of different reasons, probably because they don't feel very well. So cognitive and emotional changes are pretty common. There's a comment here about immune therapy and side effects. I won't go into a lot of detail, but important for you to understand if you are on immune therapy, what to be looking for and to have that communicated to you well so that you can report it immediately if you have it. The earlier we know about it, the better. And here's another list of side effects that you want to be aware of in regard to immune therapy. So palliative care is a form of care in which we focus on symptoms and we try to bring symptoms under better control. For example, pain or nausea, those sorts of things, or even fatigue. And palliative care can be delivered really at any time during your care. You know, it used to be thought that we'd only talk about palliative care toward the end of life, but it's not the same as hospice. It means that we're really trying to allow the patient to feel better so that they can enjoy themselves, enjoy their family, enjoy their friends, and be more productive. So in many circumstances, your oncologist will focus on that. In some circumstances, you'll get a palliative care physician to help you focus on that. Turns out that it's hard to find a palliative care doctor these days. Our practice has been trying to hire one. It's hard to find one. And I know that the palliative care doctors at Multicare and Franciscan are all very busy. This is a list of some of the palliative treatments that can be given. We didn't talk about bone loss earlier, but most of the medicines that we give result in osteoporosis or osteopenia, so they can cause a decrease in bone density. So we're always kind of thinking about a patient's bones and trying to keep them strong. Some patients receive medication for this, like a medicine called Zometa or Reclass or Prolia. Those are all medicines that are given to try to keep the bones strong and also protect them from the cancer. So many patients will be getting DEXA scans periodically for us to monitor that. This is a list of those medicines that we use. Zometa and Prolia and denosumab are the same thing. Xgeva, they're all the same drugs. So this is a maybe the most important slide of all in regard to a discussion about metastatic breast cancer. It's important to be aware that, in most circumstances, unfortunately, metastatic breast cancer isn't curable. As I said, there are some circumstances where it is, but the majority of cases, I'd have to say that it is not. So there are going to be ups and downs. There are going to be days when you feel pretty well, and then there are going to be days when you don't feel so well and feel more fatigued or have more symptoms, more discomfort or pain. There are going to be times when the oncologist comes in and says, the CAT scan really looks good. And then the next time, the oncologist may come in and say the CAT scan doesn't look so good. We have some progression of the disease. So now what? So those things happen. It's a roller coaster. And so it can be a roller coaster of emotions as well. I think going into it, when you're first diagnosed, it's probably important to try to recognize that you're going to be faced with those ups and downs. It's so important to have people that you can talk to, I think, to have a counselor, a spouse, a brother or sister, someone that you can communicate well with, to talk about those ups and downs, to maintain a level of hope and optimism. So those things are just very, very important. For many of our patients, I think that living with breast cancer that is metastatic, it's not necessarily a daily worry, that they feel as if they have some control, that they're relatively stable, doing okay. But there is always that monkey on their back. There's that uncertainty. What'll happen next week? What new symptoms might I develop? Is there additional treatment that I can get? And then also that issue of kind of aloneness. I think this is where counseling can be helpful, that if you don't have a spouse or you don't have a best friend that you can talk to, a brother or a sister, a child, a daughter or a son that you can talk to, then counseling can be pretty helpful, because being alone with this disease is not a good thing. It's hard. There are too many ups and downs. So you got to be able to communicate. This is a list of some of the issues that all of you are faced with that have metastatic breast cancer. Some more than others. Some don't have any of these. Some have all of them. I'm sure you can identify with these. One of the common issues really is that sense of fatigue and tiredness, where you, I think, have to gauge your activity during the day. If you do too much in that first couple hours in the morning and then are exhausted the rest of the day, that's not very satisfying for most people. If you're going to go out and go to your grandchild's soccer game at 4 p.m. in the afternoon, probably worthwhile taking a nap maybe beforehand, or resting, thinking about controlling your exertion, planning your day, planning to expend energy on issues that you really want to participate in. Frustrating problems occur, disruptions of work and school, home life. And I think that this is an important point, that, those things impact how you feel, how you interact with others, all of those things. So be willing to talk to your doctor or your counselor or your psychologist or counselor or husband or whoever about these things, and kind of try to openly discuss it, because everybody has these symptoms to some degree, at least, during their experience with metastatic cancer. So we talk about being optimistic and having a positive attitude. I think that that's great, but in reality, it's hard to be optimistic 100% of the time and positive 100% of the time. There are going to be those ups and downs that we talked about, and so you're going to experience those downs, and you've just got to be able to reach out to somebody that you trust and are close to, that you can discuss these feelings with. Again, just expressing your emotions and communicating. Here is a useful online resource. Lifeline.org can be helpful. I think most of uh, the practices try to put you in touch with um, either clergy or mental health professionals or counselors or social workers that can help in regard to the stresses that one experiences with this problem, with this metastatic breast cancer. And these are some ways to kind of care for yourself that are helpful. And I'm sure all of you are probably more expert on this than I am. Nutrition's important. You want to maintain good nutrition, certainly. Exercise gets rid of stress really well, makes you generally feel better. It's important. Having some social support, we talked about, hobbies. Spirituality is important. All of us um, have our own personal experience with spirituality. For some of us, it's crucial. And I think uh, for all of us, there's some degree of spirituality that's important to practice. Um, Keeping a journal can be helpful. And planning fun things. I tell my patients to, even if they're not feeling that well and are receiving active, say, chemotherapy or something such as that, plan a trip. I mean, if you can't get on an airplane and go to Paris, you can plan a trip, go to the car and go to Snoqualmie Falls. So there are things that you can do that are fun, that get you outside, that allow you to stay active and that you'll enjoy. And so planning things, I think, is important. This is a slide about the cost of care. Um, I think all the hospitals, as well as our practice, have financial counselors to try to help in regard to this. We have a foundation, or there are many foundations that actually help in regard to covering some of the out-of-pocket costs. If we can institute those to help you, we want to do that. And here's a website that can help. Finally, advanced care planning. This is something that's just practical and worth doing. So you can just get it done, and you have control of it. It's developing a living will and advanced directives, so that you can have it documented as to how far you want physicians to go in your care. Talk to your doctor about it. Talk to your family about it. What's too much? What's enough? And it may change. That some of my patients with metastatic breast cancer would frankly want to do everything they can in order to um, survive, because their quality of life right now is good and their cancer's under control. So if they were having a heart attack, they'd want their heart attack to be treated. Other patients that I have are frankly too weak and too frail because of the cancer or other medical illnesses to undergo anything like CPR. They'd never survive it. CPR can be a very traumatic event. And so the chances of returning to, living independently again are minimal or none. So it's an important topic to discuss with your family and with your doctor. Power of attorney is important for healthcare issues, but also for financial issues. This slide kind of discusses those things. Okay, this is the cancer support community numbers that can be helpful, that are staffed, that can give you some direction in some of these issues that we've discussed. I think also a great resource is our social workers and support staff. Okay, I think I'm getting to the end.
Mhm.
All right. This is the Cancer Support Community's grassroots project to bring attention to the issues of cancer and coping with cancer, the need for good social and emotional support. So I think important to support, and these folks do a great job networking on Capitol Hill to give us the tools to better help you all who are fighting this disease. So supporting them is a great policy, is a great thing to do. So I think that is all, if I'm right. Any questions?
Hi, Dr. Senecal. We did have some questions that were emailed to us prior to this workshop. The first one was a patient wanted to ask if you could go into more detail about bioidentical hormone replacement and talk a little bit more about information about it.
Well, that's a tough one for me, to be honest. So I kind of go to my naturopath to talk to them about bioidentical hormones. So in patients that have metastatic breast cancer, if it is estrogen receptor positive, we really try to avoid bioidentical hormones completely, mostly because even if they are low intensity estrogenic agents, they still stimulate the estrogen receptor. And so we're quite concerned about that having a potentially stimulating growth of the cancer, for example. So I have a patient who has a desire to use those. I oftentimes ask that they have some discussion with an expert like one of our naturopaths.
Great. And the second question that we had submitted was asking if you could talk a little bit about if a person with metastatic carcinoma, can they become a survivor?
Yeah. Well, I think, I call a survivor anybody who's diagnosed with cancer, is a survivor as far as I'm concerned, from the time of the diagnosis on. So maybe that's just a terminology, but can anybody with metastatic cancer beat it? And the answer is yes. There are some patients with metastatic disease where the cancer is extraordinarily sensitive to treatment, or that the good Lord has felt that they're going to get healed and they overcome it, that the cancer goes into remission and that it does not come back. And so I think every oncologist probably has a half dozen or a dozen patients in their practice who have experienced this, where we expect that there would be recurrence of the cancer and there hasn't been. So it can occur. It's not common, but it can happen.
And the third question that we got is, if you do get metastatic breast cancer, does it have the same characteristics as the original breast cancer?
Yeah, that's a good question. And we oftentimes will do biopsies of the metastatic disease to see if it's in fact the same, because about maybe 15% of the time, it can morph or change its characteristics. It can lose the estrogen receptor or it can gain it. It can lose the HER2 protein or gain it. So we can't rely on the original cancer in the breast for telling us what those metastases are like. So almost always we would biopsy a metastasis to determine what its character is.
That definitely makes sense. Before I proceed with the next question, I just wanted to let you guys know that we will stop the recording at this time. The next question that we got, Dr. Senecal, is